The topic today, which we are taking from module 2 in fetal medicine ultrasound, is Doppler and fetal well-being. See, basically, when we talk about fetal medicine, in fetal medicine, fetus is our patient. So from diagnosis to therapeutic, everything we have to do on the fetus. So when we talk about diagnosis in fetal medicine, see, abnormalities, structural malformations only account for 2 to 3% of the fetuses. Out of 1,000, for let's say example, out of 100 scans you do, in 1 or 2, maybe you will get some abnormalities. But if we talk about fetal growth restriction, that nearly affects 10 to 15% of our pregnancies. And if we include small for gestational age also, then the number increases further. So this part of fetal medicine where we talk about fetal well-being is more important than understanding the abnormalities. Abnormalities is important to understand, but this is something which we encounter in most of the patient. We are going to do Dopplers, but most of the time, more than doing, we don't know how to interpret the Doppler. My whole purpose of today's class is to make you all aware. You should have that understanding that which Doppler you will use when. Like, I hope everybody knows there are two types of fetal growth restriction: early onset, late onset. Early onset fetal growth restriction means the fetus itself has the problem. But in late onset, it is not the fetus, it is the demand which is increasing and the supply is not able to meet. Okay, so this is the basic concept, and the management is very different if we talk about early and late. So today at the end of the class, I hope you all know very well which Doppler you should use in your clinical practice when you sit in your OPD and you get a scan saying that MCA PI is this much, this centile CPR is this much. You should know what it means, and you should be confident in telling this baby will do okay, this baby will not do okay. That decision you can make based on the Dopplers. So when we talk about Doppler, Doppler is a part of ultrasound where we are looking at the blood flow. Okay. In obstetrics, we look at blood flow in the fetus and the mother. The source is the mother from where the blood is coming. So when we look at the uterine artery, which is the source of blood supply to the uterus where the fetus is growing, it is known as the uteroplacental circulation, which we look at. When we talk about the fetus, from the placenta, the blood will go via umbilical vein to the fetus and will return via the umbilical artery. Now, depending on the source only, the baby will get whatever the nutrition the baby will get will depend on the source. If the source is giving surplus amount of material needed for the growth, the baby will grow properly. Unless the baby has some problem like some infection or some genetic conditions, mostly the baby will grow properly. But in some babies, mostly early onset FGR, because of their intrinsic problem, because the baby itself has a problem, how much ever you supply, baby will not take it. This is first concept. Second, if the baby is okay, but your supply is less, the baby will develop a mechanism so that it can survive in that low supply. Obviously, no. If I have little money, if I have only 3,000 rupees for 1 month, for example, I will have to fulfill all my needs and demand in the 3,000 rupees. But if I have 30,000, I will live a luxurious life. I'm just giving an example for you to understand how the baby copes with the demand. With the supply. The supply is the uterine artery. Okay. So in this Doppler class, we have two parts which we have to understand. First is the mother, the uterine artery, the supplier, and the receiver is the baby. So every Doppler vessel, whichever you are going to study today, has its own signature. What does signature mean? How do we identify like individual person, like who has written? We identify it by using our signature. I will have my signature. You will have your own signatures. Likewise, every vessel has its own waveform, which is known as the Doppler signature. I want you all to familiarize with all these waveform. Let's study one by one. First is the uterine artery. See, in uterine artery, obviously any artery, whenever there is a flow, in cardia, there are two cycles, systole, diastole. In Doppler, in the arteries, these flows will be reflected. So when the cardiac systole happens, what will happen? A lot of blood will come. So the artery will show a good amount of blood flow. This is known as the systolic flow, which is happening in this particular artery, which is uterine. Then the second phase of the cardiac cycle start, which is the diastole, where less amount of blood is flowing. So this is the systolic and this is the diastolic flow. This funda is same for every vessel. If it's a middle cerebral artery, same. This is systolic and this is diastolic. If it's an umbilical, see, this is systolic and this part is the diastolic flow. This formula maintains in all the artery. Veins are quite different. Veins, until unless they are connected to the heart, they don't reflect the cardiac cycle. I'll show you a Doppler of a vein first. Let me show you. Do you see this non-pulsatile flow happening down? This top one with systole and the diastolic flow is umbilical artery, but this non-pulsatile down is umbilical vein. I'll show you one more image. See, this is the flow in the artery and this is the flow in the umbilical vein. It's a non-pulsatile continuous flow. Vein doesn't have pulsatility. In vein, slow motion flow happens, except there's an exception. Exception is which vein? The veins which are directly connected to heart. The veins which are directly connected to heart, there the pressure of the heart is reflected in the vein. Therefore, Ductus Venosus is a vein, but it has a triphasic waveform. It's not only ductus, we have other veins also. I will show you in the next slide. So for now, you need to understand that in artery, there is a pulsatile flow, which has a systolic flow and a diastolic flow. In vein, normally it's a non-pulsatile continuous flow, but veins which are connected to heart have a triphasic waveform. Okay. Having said that, let's understand how we do this Doppler scan. So we have various modes of doing Doppler. One is color Doppler. In color Doppler, we just put the color, red and blue color will come, and what we quantify with that actually, which direction the blood is going. And if there's an altered flow, it will show, and it will show whether there is any flow or not. That's all what the information which we get from color Doppler. To quantify what is the systolic flow, what is the diastolic flow, how the cardia is functioning, we need to calculate the rate, the flow, the volume, the speed, everything. That we do by something which is known as the pulse wave Doppler. This is how a pulse wave Doppler gate look like. Do you see these two lines over here? This is the gate of the pulse wave Doppler. When you put it, you will get something like pulsatile flow, and it will show you which direction, what is the velocity, everything you can calculate using this technique of pulse wave Doppler. So these are the two most common methods which are used in obstetric scan, color Doppler and a pulse wave Doppler. We also use sometime M mode, we may use a power Doppler, but we don't use it routinely. These are the two things which we use routinely. How do we quantify? I told you, we use pulse wave Doppler to quantify. Once you put the pulse wave Doppler on, this kind of waveform you're going to get. There'll be a systolic flow, there'll be a diastolic flow. But how are you going to quantify? Is there any cutoff for which you are going to quantify, and which vessel, how will you quantify it? See, in all the arteries, we have three things which we normally see in reports. If you have seen any Doppler report, they will write SD ratio, that is systolic by diastolic flow ratio. They will write RI, resistance index, and they will write PI. Let me make it very simple. In today's era, SG, RI are obsolete. We only measure one thing, that is pulsatility index. The word itself is self-explanatory, that is pulsatility. That is how much pulsatile the flow is in that vessel. And what will the pulsatility depends upon? For example, just take an example of a tube in which water is flowing, for example, and there is some block over there. Because of the block, what will happen? The flow which is happening in the tube will try to increase the pressure so that it can go through the block and travel forward. If there is no block and the tube is dilated due to some reason, the blood flow will happen very fast. So the pulsatility means how fast and how much pressure this blood should exert will depend on the resistance which is present in the forward direction. So depending on that, this artery or vein or whatever thing is there, just a tube of water flowing in the pipe. Simple. When you want to garden your plants also, you sometimes you might have done, no, you want to increase the speed of the water which is flowing from your pipe. What do? You just put pressure. You do know what happens because of that resistance, the pressure with which the water comes out of the pipe increases. So pulsatility index is the measure of this resistance. Okay. So this is the only parameter which we measure. For knowing the resistance, we measure one more thing, which is known as the peak systolic velocity, means how much this wave has achieved. And this has a utility in measuring for fetal anemia. So if anybody asks you what you measure in Doppler, you measure two things, PI and PSV, peak systolic velocity. Peak systolic velocity per se is only used in cases of fetal anemia. Means any causes, immune or non-immune, whatever is the cause of fetal anemia, this is a marker. I will explain you later why and how it is used. So this we already discussed that pulsatility index is a measure how pulsatile the blood flow is depending on the resistance to the blood flow which is present downstream. So let's start with uterine artery first, which is the first source. No, first let's understand the source. So how we measure uterine artery? You have to measure uterine artery. There are two formulas, means two methods. First is go parallel to your iliac vein, inguinal ligament. Put your probe over there. As you put on the color box, you will see this. You put on the color box, what you see? You will see iliac vessel and you will see something crossing over it. This crossing vessel is the uterine artery. And where it crosses just 1 centimeter beyond, you have to put your pulse wave and you will get your uterine artery Doppler. This is the first method which we use. Now, second method, let me tell you now first. In second method, what we do, see, we all know uterine artery at the level of internal os travels upward towards the uterus, no? Where the ureter is below the uterine artery. The water flows under the bridge. I hope everybody knows that from anatomy. So do one thing. Focus on the cervix and put on the color. Go on the right side. For example, you want to measure right uterine. Go on the right side. Put the color box in the cervix. Whichever vessel you see which is going up is uterine. Very simple. And this is the simplest method. There are two, in first trimester, second trimester, this method of doing via cervix is preferred because it's easy to focus the cervix, put the color and put the Doppler. In third trimester, when the baby has grown, no, what happens? The cervix is a lot of shadow is there when you're trying to image the cervix. Therefore, in those cases, that going parallel to the inguinal ligament and putting the color, that method can be used. So these are the two methods which we use. Now, having said that, there are few prerequisite. Prerequisite means how will you know whether you are measuring uterine or branches of uterine? Uterine has so many branches, arcuate, basal, you all know spiral. When you put the color gate over there, or after the color box, when you put the pulse wave gate over there, the gate should be 2 mm first. Angle of inclination should be as close to 0 degree. Because if angle increases, the flow will decrease. Okay. Third important point. The peak systolic velocity should be more than 60 for you to call it a uterine artery. If it is less than 60, maybe you are measuring some branch. Let me show you here. See, the PSV is more than 60 no, over here. So we are sure we are measuring uterine and we are not measuring some branch of uterine artery. This is how you are going to do it. Now, I have mentioned few more things at PRF and wall motion filter. See, you need to increase the PRF if there is aliasing happening. Aliasing means overflow of the vessels, blood flow. And you may need to play on wall motion filter if this aliasing thing is happening. So these two things you only have to touch the button if aliasing is happening, otherwise not. Most of the presets of umbilical artery which your ultrasound person will, the machine person will do and give you, they fit pretty well in most of the patients. Sometimes you may have to increase or decrease the scale or the PRF as per the requirement. Now, when you do uterine artery, I have listed here so many conditions. You do uterine artery when there's preeclampsia, FGR, all this are gone now. Today, doing uterine artery is mandatory in each and every patient. Starting from NT scan, when we do NT, we do uterine because we have to screen for preeclampsia, because prevention is there. We all are very well aware of the ASPRE trial, which came in 2017 and told that giving 150 mg of ecosprin is going to decrease your chance of early onset preeclampsia from 60 to 90% and late onset around 44%. So starting from NT scan, anomaly scan, even your growth scan, all the scans you have to do uterine artery because that's the source. If uterine artery flow is reduced, means the PI is high, resistance is high, then what will happen? Obviously, there will be growth restrictions, there can be hypertensive disorders, there can be abruption, all the complications can happen because of placental dysfunction. But make sure that you have measured it correctly and you know how to measure. So I hope everybody is clear. There are two methods of measuring uterine artery. First trimester, second trimester, you can do by just focus on the cervix, put the color. You see some vessel going up and it will have some aliasing. Aliasing means the color will be bright, popping up like bluish, little red, blue color, orange hue it will have. Put the gate there 2 mm and you will get. And you should get a PSV more than 60. If you get that, you are very, very sure that you are dealing with uterine artery. Now, second part. If the patient comes for the first time in third trimester, you cannot focus the cervix. Go laterally. Just go lateral to the inguinal ligament. Put your color. You will see uterine artery crossing the iliac vessels and you put the color just as it crosses, 1 centimeter beyond, you put your gate and you will get the Doppler. But having said that, how will you know whether the uterine artery Doppler which you have done is normal, the PI is normal for the gestation or not? For that, we have ready-made calculators, which is freely available online. You can use that free of cost. Before I show you the calculator, I want to show you this. See, if you look at this image, you will feel that there's a good systolic flow, but in the diastole, the flow is less. In this, it is better than this, but still there is a notch present. And lastly, there's a very good diastolic flow and systolic flow is always there. What is this? Is this abnormal? No. This I wanted to show you because I know everybody knows that there is something known as trophoblastic invasion, which happens. There are two waves of trophoblastic invasion, which happens in the placenta. And because of that, the uterine artery pressure decreases. So to see a notch in first and second trimester can be a normal thing. This is a normal uterine artery flow in first trimester and second trimester. And by the third trimester, as soon as the impedance decreases because of the trophoblastic invasion, you will have good amount of flow in the diastole also. So based on this funda, the cutoffs are high in first trimester because we know naturally also the cutoff will be high only because the flow is less in first trimester. As the baby grows, trophoblast invasion happen, villi expand, pressure goes down, flow increases. This funda I hope everybody is clear with. So whenever you see this kind of thing that there is a notch, don't just mention. Many times people will report notching seen. Notching has no value. If the PI is normal, notching is just a structure. You see a dip in the diastolic flow, that is known as notch. Many times in uterine artery report, you would have seen that notching seen, notching present. Notching is nothing. If the PI is high, you should be worried. If PI is normal, no need to worry. Okay. So how you calculate it and how you will get it? See, any PI more than 95 centile, you have to worry. How will you know whether it is 95 centile? This is free calculator by FMF, Fetal Medicine Foundation. Just put the uterine artery values. Once you calculate, value will be shown. I think you all have seen here. Here in this corner, these are the values which is written there. You just have to take these values and put it over here and you press on the calculate. It will give you the centile and the z-score. Okay. Any z-score which is more than +2 standard deviation 2 SD or less than -2 SD is concerning. Or centile is simple, more than 95 centile. kindly mention in your report uterine artery PI more than 95th centile. Okay. And if it is less than 28 weeks, kindly go and start her on EcoSprint. That is most important take home message. See, this recently ACOG has changed, updated its guideline. Previously, we used to start EcoSprint in first trimester, and max to max by anomaly scan, we used to start EcoSprint. But now, in 2022 guideline, it has updated a little, and it has said that upper limit of starting EcoSprint can be up to 28 weeks. Having said that, it is not that it is going to give 100% result. Later we start, results are not good. Earlier we start, results are better. So if you have the opportunity, you did NT scan, you picked up that uterine artery PI is more than 95 centile, kindly start her then and there. But if in case patient comes to you 24 weeks, you are doing a growth scan and you find uterine artery PI is more, you are suspecting fetal growth restriction, preeclampsia, FGA, everything can happen. Whatever happens, we don't know what will happen, but patient comes in the high risk category. Now at 24 weeks, you don't know what to do. Please start it, maybe, but tell them that the efficacy goes down as the gestation age increases, but still as per recommendation, we try to give so that we may avoid as much complications as much we can. Now, as I told you this point slide I've already discussed that seeing a notch is not a problem. In 65% cases, notch may be present, which is normal up to 20 weeks. If the PI is abnormal, please be worried about that and try to help the patient by giving EcoSprint. Coming to the next, we finished on the maternal part. Any query in uterine artery, in the method of doing, in the reporting, in understanding how to interpret the uterine, kindly put in the chat box. Now we are starting second Doppler. I have 6-7 Dopplers for you. So kindly pay attention to it. So let me first start by making you understand what umbilical artery does and what is the umbilical artery. So let's make it very simple. I'll make it very simple. What happens? From the placenta, umbilical vein takes the oxygenated blood to the baby. From the baby, the deoxygenated blood comes via umbilical artery to the placenta for oxygenation, and then it is returned back. This circle goes on. So, like uterine artery, as you understood, as the baby grows and the placenta grows, more and more villi are formed. So, the resistance of the placenta goes down as the gestational age advances. Umbilical artery drains where? In the placenta. So placenta is the downstream for the umbilical artery, no? So the whatever pressure is there, if placenta is very small, placenta is not formed properly, umbilical artery is going to have difficulty in sending the blood to the placenta. So umbilical artery has to increase the pressure and all those problems will happen. So like uterine, in umbilical artery also, as the gestational age advances and the placenta grows, I'm talking about normal healthy pregnancy, umbilical artery PI decreases over time. I hope you can understand and you can understand what I'm saying. Umbilical artery PI decreases over time. Why? Because the placenta, which is the resistance bed for the umbilical artery, is growing over time. Okay. Second thing, I'll just tell you now itself. Later you will understand the importance of it. What does umbilical artery does? It brings the deoxygenated blood from the baby to the placenta. Due to some reason, if placental pressure is very high and the umbilical artery is not able to remove the deoxygenated blood, what will happen? All that deoxygenated blood is going to stay in the baby. And if you don't have oxygenated blood and so much deoxygenated blood, what will happen? The baby will have hypoxia, the baby will have acidemia. That is why many a times when the baby don't cry, in patients where there is Doppler abnormality absent in diastolic flow, they become prone to hypoxic injuries, that is HIE. They will have HIE because the umbilical artery was not able to perform because of the resistance in the placenta. This is very, very, very important point. Okay. Now, as I told you, as the gestational age increases, can you see over here? Here there was no flow in the diastole. No flow. No flow. Gradually, can you see? The flow is coming up. So, umbilical artery resistance decreases over time and the flow increases over time. Umbilical artery has a sawtooth pattern. I think by now everybody will be able to actually, if anybody gives you the Doppler image, you will pick up this is umbilical artery at least. And vein, I told you it is a non-pulsatile continuous flow single line. Okay. Now, how do we do umbilical artery? From the placenta, the umbilical artery arises. There's a free loop and it goes and attaches to the fetus. We all know this. In the umbilical cord, there are two artery and one vein. Okay. And there are three ends we can do. We can do at placental end, we can do in the free loop, or we can do at fetal end. Which end do we prefer? There is a difference in the value if you do at placental end, fetal end, or the free loop. See, mostly we do the free loop because whatever graphs and charts we have for calculating the PI percentile is for free loop. You can do at fetal end. Fetal end has highest resistance. And you can do at placental end, which has the least resistance. Why? Why I'm saying this? The placenta, where the placenta is there are a lot of vascular channels are there. So the flow is very good. So at that end, you will get least umbilical artery pulsatility index. But at the fetal end, they come and constrict in very small. So the pressure itself is high. So the PI will come high naturally. So to make a balance of these two extremes, very low and very high, we take the free loop. That is why most of the charts are made on the free loop of umbilical artery. Okay, so you can use any, but you have to choose a chart like as per your practice. If you want to take the placental end, okay, you can take, but choose a chart which calculates PI as per placental end. Most of the chart which is available, which is freely available, is on the what to say in the free loop. They have calculated based on the free loop. Now, if we talk about, as I told this, you have understood this just slide in the slide, whatever is written. Only one thing I need to add in this is, I told you there are two umbilical arteries and there is a one umbilical vein, but there are many cases where there is a single umbilical artery. And can you imagine if there were two routes for anything, like if there were two vessels which were taking the blood, but now suddenly what has happened? The two vessels fuses together, and now there is only one vessel present. So what will happen? That vessel is going to dilate. Like you might have read about compensatory hypertrophy in cases of renal agencies. If there's one kidney, for example, if there's just one kidney, so that one kidney is going to increase its size so that it can compensate for the function of both, no? Similarly, if there's a case of single umbilical artery, the PI will be less because both the vessels are going to fuse and decrease the flow. So ideally, we should use charts and graph for single umbilical artery, which should be separate, but we don't have that available. Recently in 23 and 24, few papers came up, but still it's not like, it's not in the practice because they are not standardized charts are not available. Okay. So now let's understand this. I have shown you in first trimester. If you don't see any, what do you see here? There's umbilical artery flow in systole, but no flow in diastole. This can be normal in first trimester. I had a case, I remember 3 years back, my colleague called me and told me, ki, madam, yeah, my colleague called me, I remember. She told ki one of her colleague, she was herself a doctor, her pregnancy was terminated because in first trimester, the umbilical artery was showing absent end diastolic flow. Maybe that was abnormal. Maybe there was some aneuploidy, there was something else coming up, we don't know. But doing a termination, maybe it was normal. But as per normal physiology, umbilical artery flow may be absent in first trimester. So kindly don't take decisions which are not, we cannot change. So termination is something which you have done. You could have followed the pregnancy instead of going for termination. As the gestational age advances, the placenta grows, so the resistance for the umbilical artery goes down and the flow increases in the diastole. I have put the images for you over here. And as I was talking, how the PI changes. See here. See, at 30 weeks, I'm taking 50th centile, for example. The PI was 0.93, but by 35, it became 0.8, and by 40, it became 0.77. This is normal, no? 50th centile. So can you see how the PI is decreasing? This is normal. The pressure goes on decreasing as the baby is growing. Okay? when we talk about the abnormal values, I told you there are many papers, they'll tell you SD ratio more than 3, RI more than 8, 0.8, all this are gone. These days are gone. You have a very simple and a clear-cut method, okay, where you have a calculator. Just put in that calculator and you will get the values. Now, I hope you all can identify this image very well. What is this? No flow in the diastole. That is absent end diastolic flow. What is here? Here, instead of absent, the blood flow is reversed. Do you understand this? Why this happens? Let's understand. You have a placenta. The blood was coming via umbilical artery in the placenta. Placenta has a lot of pressure over here. Umbilical artery tries to put blood, but it tries to narrow down itself, increase the pressure so that some blood may go. Okay. Till some limit, it may be able to do that by increasing the PI. But once the pressure is too high in the placenta, umbilical artery is not able to send any blood. What will happen? Absent. No flow is happening. If it goes beyond that, pressure here becomes so high that it starts sending blood back in the umbilical artery. That is when you will see reversal. So it is like a stage-wise progression. The baby is worsening. Okay? This is how umbilical artery absent and reversal will look like. So this slide only I was trying to explain to you. So first the resistance will increase. Why? Why? To actually make some blood go to the placenta. That also fails, there'll be no flow. And eventually the placenta will have more pressure and it will start sending blood back to the baby. So this is what happens in increased PI, absent and reversal. This is like stepwise, it keeps on happening as the placental function is worsening. Okay. So whenever there is absent flow, what does it mean? There is no blood. The deoxygenated blood is not getting cleared from the baby's body. So chance of hypoxia is 80% and acidemia is 46%. But if the flow is happening, chance of acidemia is just 0%. So umbilical artery is a very important part in monitoring of growth restricted babies. It may show abnormality in 90% cases before the CTG shows. That is the whole sole purpose of doing Dopplers, because CTG biophysical profile are last to be hampered. By the last, when we go, if 46% chance the baby is already acidemia has happened, the baby brain is injured already, then we cannot help the baby. We as a fetal medicine, our role is to pick these baby here itself when the flow is just, PI is just increasing and flow has started to decrease in the umbilical artery. Pick at that level and try to intervene then and there only before the acidemia sets in. Talking about umbilical vein, we know it's a non-pulsatile flow, but because venous Dopplers are always related to cardia. Whenever the heart is having failing, it will be reflected back in the venous Doppler. So whenever the central venous pressure is rising, baby is having hypoxia, acidosis, this flow will become pulsatile. Let me show you how it will change. Why I'm telling while it will become pulsatile in umbilical artery, I'll show you here. Let me just show you now. Do you see this is the umbilical vein which is entering the baby? And this umbilical vein is connected to which vein? Ductus. And ductus is connected to the heart. That is why umbilical vein will show pulsatility. When the heart is failing, it will reflect in ductus. Then ductus will go and reflect in umbilical vein. That is why specifically umbilical vein pulsatility is a marker that the cardia is having problem. Okay. Now coming to next vessel, that is middle cerebral artery. We understood the maternal supply. We understood how the baby clears its blood. Now we have to understand how the baby copes up when there is hypoxia. We know brain is a very sensitive organ in terms of oxygen. Whenever there is hypoxia, the brain cannot tolerate it. The body does one thing. Body only knows to protect the brain and the heart. From all over the body, the blood will be sent to the heart and the brain. Therefore, whenever there is hypoxia happening, these blood vessels, the brain vessels will dilate so that we can compensate. Because what hypoxia means? Hypoxia means that the amount of oxygen dissolved in the blood is less. Point number one. So when the amount of oxygen dissolved in the blood is less, we want to change the blood more frequently. So what we will do? We will increase the flow in the brain. How we can increase the flow? By decreasing the pressure of the artery which is supplying. There are various artery, anterior, middle, posterior, so many are there. But for fetal medicine purpose, the artery which we study is middle cerebral, which supplies the 80% of brain cortex. That is why we use that. This is one reason. Other reason is for any Doppler, we want an angle of 0 degree. Therefore, if you put this is one artery, it is going straight. No, when you put the Doppler, you get a angle of 0 degree. This is another reason why middle cerebral artery is preferred. So how do we do it? Take our axial section of the brain like this. Just go below where you see the CSP, just go one level below. You will see circle of Willis, put on the color box. The vessel which you see going along the sphenoid bone is the middle cerebral. You have two options. This is near field, this is far field. You can choose either. You can put gate here also, that doesn't make a difference. But the vessel which travels along the sphenoid bone that you have to choose, that is the middle cerebral artery. You have to put the cursor here, just where it divides. The circle, this is a circle, it divides. You put the cursor here. In proximal 1/3, you have to put the cursor, 2 mm gate, and measure angle F0 better. Don't put too much pressure on the head. Now, you take 3 to 6 waves we take and we calculate we put the auto button and it will calculate PI, RI, PSV, everything will be calculated. Why we choose MCA only, not anterior cerebral, posterior cerebral, I told you. It is reproducible because of the angle and the position of the vessel. That is why most of the papers have looked at middle cerebral artery in cases of FGR and hypoxia. Therefore, this vessel is the most studied vessel. Now, I told you brain wants oxygen. So how it will get oxygen? By dilating the vessel. So whenever there is hypoxia, the change which happens in the fetal brain is vasodilation. Therefore, the PI will go down. When vasoconstriction happens, PI goes up. When vasodilation, PI goes down. This is a very important understanding. Therefore, let me make a statement. If you don't understand, put in the chat box. Early onset FGR, because those babies are deprived of oxygen from the beginning itself, they will show brain sparing effect, that is dilatation of the middle cerebral artery as a routine. But late onset FGR, where the brain is not ready to accept low oxygen, if there is decrease in the PI of MCA, the baby is going to have worse prognosis. Again, I'm repeating. Early onset FGR, low PI of MCA can be a normal thing because the baby is trying to compensate. Late onset FGR, the baby cannot compensate because the amount of oxygen required by preterm means around 34, 36 weeks, brain is too much. The baby cannot compensate. Baby wants oxygen. And at that moment, if you see a abnormal MCA or a CPR, you are going to intervene. This is the core difference in management of early and late onset FGR. For early onset FGR, we don't decide on delivery based on CPR or MCAs because they will be abnormal because the baby is compensating. But late onset FGR, we decide delivery on MCA and CPR because the baby cannot compensate. Baby wants lots of oxygen. Okay. Now, I told you one more thing we measure, that is the peak systolic velocity. I told we will discuss about anemia. See, anemia also like hypoxia. When my hemoglobin concentration is low, what my body does? Body tries to circulate the blood faster so that it can compensate for the less amount of blood. Because of that reason, the peak systolic velocity goes high whenever there is anemia. Okay. So if we talk about clinical application of anemia, how we do it? We just have to calculate the same MCA. How you are doing MCA, just do it like that. Put the color box, put the pulse wave Doppler, you will get MCA. PSV. This MCA PSV, if it is more than 2 times gestational age, then you should be worried about anemia. For example, At 22 weeks, if it is more than 44, you have to be concerned that the baby is having anemia. If 30 weeks, if it is more than 60, you have to be concerned that it is going to have anemia. Twice the gestational is the cutoff which we take for you to classify whether baby has anemia or not. This is a simple layman thing I'm telling you. Like sitting in OPD while doing scan, you cannot, if you don't have the option that your staff will open and tell you whether the baby has anemia or not, you can use that. Otherwise, this is a manual calculator. 20, it should not be more than 40. 30, it should not be more than 60. It should be less than that. Otherwise, you have this free calculator by perinatology, FMF. Everybody offers you a free calculator. You put the gestation, you put the PSV, it will tell you whether the baby has anemia or not. Pretty simple. Now, just now I used a term called CPR, that is Cerebroplacental Ratio. This is a ratio of MCA, middle cerebral artery PI, and umbilical artery PI. Basically, this is one marker where we are combining both the baby, how the baby is coping, and how the supply is. So we are combining both. So obviously, this becomes a better and sensitive marker for hypoxia than MCA alone. I hope you understand. See, CPR is MCA PI divided by umbilical artery. So this marker, we have included the brain, the body's coping ability, and the supply, the umbilical artery also. So CPR is very sensitive. It will become abnormal before the MCA. I have a graph, I will show you, then you will understand this better. And I want to tell you, recently my paper is about to be published in, that is on CPUR. We have also included the uterines, which is the main source in this. And we found that that is even better than CPR, but it's still under publication. Maybe in next few months you will have it. That is going to, that was what has actually shown that in late onset FGR, CPUR is better than CPR. That is cerebroplacental uterine ratio, but it's yet to be published. Now, as I told you, in babies with FGR where CPR is abnormal, their cognitive function and achievements were bad as compared to a baby whose CPR was normal. This is the importance of CPR. For CPR also, you have cutoff, you don't have to mug up anything. You have formulas, you just need to put in these, you put the gestational age, you put what is umbilical, what is MCA, it will calculate CPR, it will give you centile, automatic, done. Nothing you have to calculate manually. Now, all the guidelines, FIGO, ISWOG, everybody is telling that CPR is a very important parameter in fetal growth restriction management, specifically in late onset fetal growth restriction. Okay. Now, before I go to management and I show you the graph, let's discuss the final Doppler, that is the Ductus Venosus. See, umbilical vein brings the blood from the placenta to the baby. 75% goes to the liver by hepatic, in the hepatic and the portal system. 25% enters the ductus. And see, this is umbilical. Most goes here, but 25% will go straight in the ductus. And this straight will directly go through the foramen ovale to the left side and to the brain. We know, no, there is no mixing of the blood in the baby. Through foramen ovale, the oxygenated blood will directly reach through foramen to the brain. It will be supplied. So that is why ductus is very important. And I need you to remember this image, very important. I'm not going to go into details of portal system anatomy at present because the lecture is not about that. But you have to understand that it is a straight vessel which arises from the umbilical vein, directly goes and drains into something known as sinus vestibule, where the hepatic vein and the IVC, all three vessels are draining. Therefore, IVC, hepatic vein, and DV, because they drain in the sinus vestibule, one common position in the baby's right atrium, all these three are going to have a triphasic waveform because they are directly connected to the heart. Because they are directly connected to the heart, when the ventricular systole happens, they will have a S wave. When the diastole happens, they will have a D wave. And even when the atria contracts, they will have a wave. In DV, ductus venosus, all the three waves are positive. That is above the baseline, S, G, and A. But in IVC, this A wave is negative. Normally it is negative. Why? Why? The answer is here. See, ductus venosus straight vein, as the gestational age increases, no, what it does, no, it becomes narrow, narrow, narrow. When it becomes narrow, what will happen? The speed will increase. Therefore, ductus venosus, the pressure is more. So when the atria is contracting, the pressure is so much in DV that the blood flow doesn't go back. It is positive always. But in IVC, the pressure, IVC is a vena cava. In vena cava, the pressure is not high. Therefore, our A wave reversal is normal in IVC. A wave reversal is abnormal in DV. Write it down. If you don't understand, put in the chat box. I'll explain. If you don't put in chat box, I'll think you have understood it. So a negative A wave in DV is abnormal and negative A wave in IVC is normal. Okay. Having said that, I hope you have understood what all opens in sinus vestibule and why there's a triphasic waveform. DV is one vessel which is answer to all the questions. It is used for aneuploidy screening, for FGR, for arrhythmia, for cardiac anomaly. All these things we use, doctors. We know, no? We do in NT scan, we do look at A wave abnormality. For FGR, if the heart is failing in early onset, to plan on delivery, we wait for DV abnormality. For picking up arrhythmias, we need this. And for cardiac anomalies also, we need this. One thing more I can add over here is the portal system. In portal system malformations also, we need to look for DV, where the DV is draining. Okay. So this slide I've already taught you. I think you all have understood that. Now, how do we do the DV? Now, the few people think it's very difficult. DV is very easy, very, very easy. If you are doing in first trimester now, in the parasage, you just put on the color. The place where you see aliasing here, just put the Doppler. That is the DV. No confusion. It's very simple. Just put the gate over here. As you put the gate over here, you will get the ductus venosus waveform. To not confuse it with the IVC, you know the A wave should not be negative. Other method is do a parasagittal section. You see this is going and draining there, and you just put all the color on the aliasing present over here. Aliasing is this orangish bluish hue what you see. Like umbilical, like uterine, in DV also, as the gestational age increases, the amount of flow in diastole is increasing. Can you see here very less flow? Here more, here even more. Okay, because the pressure is going down, the DV flow will gradually increase as the baby grows. So whenever this M pattern is lost, kindly wait before reporting. The baby should be quiescent. The baby should not move. The excessive breathing movement should not be there. If mother has just now eaten and come, the baby will move. Lot of energy. So, just wait for some time before you report that there is A wave abnormality or whatever is happening. So, all Dopplers should be done when the baby is not moving at all and the baby is in quiescent. So DV basically reflects what is happening in the heart. Now, this is how a normal ductus venosus waveform look like, and this is how a A wave reversal looks like in DV. So if we talk about importance of DV in first trimester, it can be a marker of aneuploidy, it can be a marker of cardiac abnormalities. In growth restriction, it tells about the cardiac function and help in timing the deliveries in early onset FGR. In twin-to-twin transfusion, it can tell about the cardiac overload. And even in heart abnormalities, congenital cardiac abnormalities, we need to look at the DVs. DV abnormality can help us in picking those. Now, this is a very, very important job. If you understand this, you understand FGR completely. See, let's start stepwise. The placenta was not good for the baby. Now what happens? Because the placenta was not good, the uterine artery tries to increase the pressure and send blood to the placenta. Somehow the uterine artery is sending the blood by increasing the pulsatility index. Baby is trying to cope with that less amount of blood. What baby does? Baby dilates its vessels in the brain, decreases the PI of the MCA so that it can tolerate the hypoxia, which is going to come later. So, as I told you, before MCA, CPR becomes abnormal because it is incorporating both these things. Okay. So, first thing which will become abnormal is CPR. Then after CPR, you will see abnormality in umbilical. Then you will see in MCA. By the time you start seeing an MCA, the hypoxia has started. Now, if it goes on worsening from here, the umbilical artery from increased pulsatility will go to absent and reversal. By the time from absent to reversal happen, the acidosis sets in. When acidosis sets in, the DV also starts to show changes and the pulsatility in DV increases. And if DV starts showing A wave abnormality, the baby is not going to be saved if you don't take the baby out in next 6 hours max to max. See, it is this part of the graph where you see that CTG and BPP, biophysical profile, is becoming abnormal. We don't want to intervene here. We want to intervene here. That is the whole sole goal of us understanding the Doppler's importance in fetal well-being. So from the beginning, if you know the CPR is abnormal and the umbilical artery is started to show, keep the patient on good surveillance. And if she reaches 34 weeks, depending, there's a there's a stage-based protocol given by Barcelona, which we follow in FGR. I'm not discussing that today, but still, for you, you should understand that we have to pick these Doppler abnormality at this stage itself. We don't want to pick from absent and reversal where hypoxia and acidosis already have started to set in. Okay. So try to do Doppler in each and every growth scan which you get in your OPD so that you become familiar and you start interpreting. If you are delivering the baby, also good. If you're not delivering, please take follow from the gynecologist who has referred to you and ask them how was the baby's outcome when the Dopplers were abnormal. Likewise, you will understand that whether you could have picked up even earlier, then you can counsel the patient in that way. The patient also will understand that they will not undergo all these consequences which they are suffering now. Long ICU stay, baby having HI, all those are very bad. So these are the normal things what we do in Doppler. Now I'm going to introduce few new things. Few of you might have heard about it, few may not. So these are recent things. Few people have started doing it. Most people are still not doing it, but I want you all to be aware that these things also are possible with Doppler. First is ophthalmic artery. I told you, we do uterine artery Doppler for calculating the risk of preeclampsia, correct? But now, ophthalmic artery is coming in a big number, big way. We have started doing, just put the linear probe over the eye and measure the ophthalmic artery Doppler. See, this is how we measure. This is the signature waveform. We measure PSV2 by PSV1, and this ratio is used for calculating risk for preeclampsia. If you don't have option of doing SFLT, PLGF, all those things, adding a ophthalmic artery Doppler can help. Even instead of uterine, you can use this. Charts are freely available. You can use this and calculate the risk for preeclampsia. IVC Doppler, I told you, there is a triphasic waveform, and this is normal. If you see such kind of waveform in DV, it is abnormal. But for IVC, this is normal for IVC. So in IVC, there is a normal A wave reversal. But if this A wave reversal goes so much down, this tells that the baby heart is failing. Okay. So A wave, small A wave is normal, but this large amount of flow is abnormal. Now, coming to PASS, what is placenta accreta spectrum? We know with the advent of color Doppler imaging, now we are picking up placenta accreta so easily because of these vessels. When we put on the color, no, we can easily see this hypervascularity. We see vessels bridging, good amount of flows in the lacuna, and this helps us in picking placenta accreta very easily. Even because until unless we suspect and we pick, we cannot help the mother, no? Many times, I think 1 month back, I had a cake, she came with APH and she was not diagnosed as placenta accreta, and that was a 30-week scan I did. It was a increta, placenta increta. I went for cesarean also for that, and we had to do obstetricectomy with the bladder repair for the patient. And she was not even told that she has such kind of symptoms. Therefore, putting a Doppler behind the placental bed, specifically in cases of low-lying placenta or in cases of previous cesareans, we need to do it so that we can help the mother. Now, if we talk about utility of Doppler in first trimester, we use uterine artery for screening for PE. We use ductus and tricuspid for aneuploidy screening. We use MCA not in first trimester, later for monitoring of the baby, anemia, and FGR late onset. Second trimester, we use uterine, umbilical, MCA, DV, all these we do. MCA for fetal anemia also we do. And third trimester also late onset FGR monitoring we do. So these are the major roles of Doppler, what we use in obstetrics. So today take home messages, please use the Doppler judicially. PI is the only thing which we do. Don't report SD and RI, those are obsolete. PSV in cases of anemia. For everything, you have specific charts. You cannot keep, if you cannot do manually the charts, train your assistant in using that FMF freely available charts. And Barcelona, pregnatology, all of them offer free charts. In your mobile, you can just put the PI in gestation and you will get the percentile for the patient. Okay? Document properly whatever you are getting, because what is the next step, what is going to happen will depend on this value, no? For example, if you have a high umbilical, you are expecting that later maybe it may become absent. So based on your value only, the gynecologist is going to plan her mode of action, like how frequently she needs to write the scan for the patient, when should she deliver the patient, when she should do the anesthesia of the patient. So these are very important. And anytime you have a Doppler report, no, please try to correlate it clinically. At 24 weeks, somebody writes CPR less than 5 centile, brain sparing effect. You should not worry, no? You know that is a coping mechanism. That is a normal thing which you will see at that gestation. But if at 34 weeks, somebody writes CPR less than 4 centile, I will do NST, I will do DFKC, I will repeat the Doppler after 3 days, and I will keep her under surveillance. I will not lose that patient. Okay? So you have to take the entire clinical scenario into mind before concluding. So these were my take-home message. This is very important for you all to understand. If you have any doubt, you can clarify it. Maybe if next class if we take, I'll give you the understanding of how to adjust the PRF and the wall motion filters. That is whole soul physics part. That is not clinical part. But you need to understand that also. In next lecture, maybe we'll deal with that so that you understand that part also, like how you play with your machine and the buttons to adjust those things. But this clinical concept should be there, because this I took first because I want you to start applying in your OPD. You should start applying this in your OPD from today itself. So this is very important. Any doubts, please, you can ask.